I'd like to share a very typical patient journey, and it may begin with a medical provider who has seen a patient for, let's say, abdominal pain and diarrhea, and the provider does endoscopy, colonoscopy, imaging, labs, and comes back to the patient to say, it's just IBS. Keep taking your medication, and I'll see you back in 6 months or a year if you still need me. And oftentimes a patient is thinking, you have got to be kidding me. I feel terrible. You have got to have missed something. You must have missed something. And I can't live with these debilitating symptoms that are really wreaking havoc on my quality of life. And unfortunately, this is how a lot of people that live with irritable bowel syndrome, which is incredibly common, feel. And in fact, recent survey studies have shown that the majority of patients living with IBS would give up 10 to 15 years of their life for an instant cure. And further, patients with IBS would also take a hypothetical medication if it would cure their IBS, even if it had a 1% risk of death. So this indicates that people that are living with IBS, which can be classified as having abdominal pain for at least 3 months with 2 or more of the following symptoms related to their defecation. So they have changes in frequency of their stool, as well as a change in their form. And the diagnosis of IBS can be constipation predominant, it can be diarrhea predominant, it can be mixed, and then there can also be an unsubtyped IBS. And so I think this is really interesting because this patient population is suffering with abdominal pain. They're also experiencing variations in bowel symptoms that can be embarrassing and can lead to avoidant behaviors of either food or social situations for fear of, I don't know when I'm going to have a bowel movement, and I certainly don't want to get stuck on the toilet. So there can be a lot of stigma associated with this diagnosis of IBS. And IBS is the most prevalent of what we call disorders of gut-brain interaction. And this used to be kind of labeled as functional bowel disorders. And in recent years, the Rome Foundation, which are responsible for the diagnostic criteria of IBS and other disorders of gut-brain interaction, they started to use that terminology because it really is more fitting for the experience of these diagnoses, which are really related to dysregulations between what's happening along your central nervous system and basically that superhighway of communication between your brain and your gut called the brain-gut axis. Now, we know these diagnoses are very common, and in a 2022 survey, this was a global epidemiological study that looked at 26 countries. Just over 54,000 people were surveyed, and out of those 54,000 people, 40.3% met criteria for a disorder of gut-brain interaction. The most prevalent of those diagnoses is irritable bowel syndrome, but they can also include things like functional abdominal pain or functional diarrhea. And so when we look at those that had one DGBI, just over 32% met criteria for having 2 of these diagnoses. And this is really profound because those that have more than one disorder of gut-brain interaction were found to have lower quality of life, they have more psychosocial issues and stressors, and they had higher rates of doctor's visits and higher healthcare utilization. So with this many people globally impacted by, their gut health and these diagnoses that impact their digestive functioning, it's so important that we address it and we talk about it. IBS, as I've said, is the most prevalent of these diagnoses. And in the United States, about 45 million Americans are experiencing this diagnosis. And we also know that women are affected more than men. So the ratio of women to men is about 2 to 2.5 to 1. Now, this is also important when we think about the realities of this type of diagnosis. So I talked about the physiological effects of having frequent diarrhea or constipation or that fluctuation of going back and forth. But we also have likely heard, too, about the bidirectional impact of IBS and mood disorders and anxiety. And so people that are living with IBS have a threefold higher risk of having anxiety or depression compared to healthy controls. And in fact, the prevalence rates of depression in IBS are nearly 30%, and the prevalence rates of anxiety in patients with IBS are nearly 40%. And nearly 1 out of 4 people will have co-occurring anxiety and depression. Now, I'll dive a little bit into really the bidirectional kind of impact of these psychological factors, because we know that people that have IBS have these higher prevalence rates. And now what causes the anxiety or depression can also be bidirectional, meaning that having IBS can cause anxiety and depression. And then also having anxiety and depression can lead to increased rates of IBS. So finding the right mental health provider and the right members of the team is also very important. So the brain-gut axis, I've mentioned it a little bit earlier, but it is a very widely studied and very well understood pathway between the brain and the body. And broadly speaking, the brain-gut axis is made up of our central nervous system, the autonomic nervous system, the HPA axis, and our GI tract. And I've talked a little bit about this bidirectional pathway, but this is why anyone that's ever been told that your IBS is in your head, in a way, yes, but in a very complex way, and never in a way that dismisses your diagnosis. So your brain up in your head and your gut are constantly communicating between your brain-gut axis. And the brain influences the gut in ways that affect how quickly or how slow your motility happens. So secretions that happen in your digestive tract, nutrient delivery, your microbiome, and immune function. So these are ways that your brain are impacting the functioning of your gut. And your gut influences neurotransmitters that can be produced in our gut. So our gut is actually the house of the most serotonin in your body. A lot of people think about our brain as housing serotonin, which it does, but the majority of serotonin production is actually in our gut. And stress and anxiety can impact these neurotransmitters. And that can also then impact our mood and our behaviors. So it's so important that through these systems, how the brain is interpreting signals from the gut and regulating GI functioning, our emotional states and stress can have an impact on this functioning, and therefore can be targets utilizing brain-gut behavioral therapies. Serotonin is a chemical that carries messages between nerve cells in the brain and throughout your body. And 95% of serotonin is produced in your gut. And it plays a very key role in, different bodily functions that can include our digestive health, but also our mood, our sleep, and, different aspects of our immune system. So if serotonin levels are either too low or too high, this can lead to increased, not only psychological problems, which I think is what a lot of people think of when they think about dysregulations in serotonin, but actually those dysregulations and levels can have a profound impact on our digestive health. And therefore, that's why, again, we use some of those neuro to help with some of those dysregulations and our considerations in patients that are living with digestive conditions. So let's take a closer look at something that we all have, a gut microbiota, which is a part of our brain-gut axis, that communication or that factor that is at play with the experience of IBS. And we also see that there are differences in the microbiota composition of people that are living with IBS. And people that have IBS were characterized as having a more diverse gut microbiota, and this can be good in some respects. So we want to diversify our gut microbiota with different nutrition and eating a wide variety of different plants and vegetables. But we can also have more bacterias, and that can impact the experience of different digestive conditions within our gut microbiota. So we want to think about a variety of factors when thinking about our gut microbiota. And really the reality of this is that Science is learning more and more about this unique, you can think about it as a unique fingerprint that's within our digestive tract for each individual. And so that's where taking into consideration something like a probiotic. Two people can take the same probiotic and have the exact same symptoms, but one gut microbiota may be a better fit. So it's almost like finding the right puzzle piece for that person. And the other person could take the same microbiotic and their microbiota is different and they might not experience improvements in their symptoms. So it's really something that we need to take into consideration and also know that the science and the literature is still emerging in this area of study, but it's also very exciting, especially down the line when we think about precision medicine and tailoring different types of medications and probiotics for our patients. We also have to recognize that we still don't talk about these diagnoses as much as we should and we need to. And a recent study showed that 1 in 5 people with IBS do not want to discuss their symptoms with a provider. And as somebody that talks with patients about GI symptoms every day, I know that some of the reasons are because they're embarrassed. Sometimes they've been told that their symptoms are in their head and they just have to live with them. And so they just don't want to go down that road again. But I think that our job in the world of healthcare is to first explore what's going on. You know, how do we destigmatize digestive health, which impacts all of us, as well as recognizing that, you know, there are available treatment options out there to help these individuals that are living with IBS. And as we mentioned earlier, there's profound psychological effects, and again, that bidirectional way that if we don't address, we have men and women that are living with lower quality of life, more mood symptoms, more stress, and that just makes their overall functioning in this world more difficult. So it's our job as healthcare providers to really improve this number and make it more accessible. And really, one of the reasons I co-wrote Mind Your Gut is because we know that people are still looking up their symptoms online. They're still seeking, you know, potential answers and resources. And so we want to make sure that when people maybe are not ready to talk with their medical providers just yet, when they are going to the internet, they're finding science-based information, and hopefully they're starting with Mind Your Gut. The pathway to a diagnosis is oftentimes very different. And a lot of times we can conceptualize a diagnosis of a disorder of gut-brain interaction like IBS using a biopsychosocial model. And so first we want to identify symptom triggers. So like I said, there may be certain foods. We can do a gentle food cleanup or a gentle diet cleanup, we call it in our book, Mind Your Gut, where we're not restricting your diet heavily, but we might look at how much caffeine are you consuming, maybe taking a look at alcohol consumption and making some alterations there, but also looking at the effects of stress and mood. Further, we look at the impact of your digestive symptoms on your daily life, and you don't have to do all the treatment all at once. So if you really would like to address your nutrition with a dietitian, then maybe that's where you start. If you're open to trying some medications with a gastroenterologist or doctor first, then maybe you try that for a little while and see how you respond. Or maybe you really recognize that the stressors in life that, you know, drive you to the bathroom are things that you want to address. Maybe you consider working with a GI psychologist first. But I think it's really important to recognize that somebody that might also be living with more severe symptoms of anxiety or depression or untreated trauma, those patients really need to prioritize their mental health first before working with a GI psychologist or even sometimes a dietitian, because it can be more difficult to engage in those types of therapy if your mood is not stable. So just something to think about that, you know, especially if mood symptoms and anxiety are not related to living with a digestive condition, it's really important to prioritize mental health with a general mental health provider. Also, we want to explore other physical health comorbidities. So, as I mentioned, there can be other gastrointestinal conditions such as inflammatory bowel disease that are a different diagnosis requiring a different treatment plan from what we would recommend for disorders of gut brain interaction or something like IBS. But there are also urological and gynecological comorbidities that you really want to explore with your gastroenterologist or maybe another medical subspecialty. And then also, when you're thinking about your pathway, not just to diagnosis, but to treatment planning, what do you value? What are your preferences as an individual for how you want to address your treatment plan? Maybe you've tried medication and you really are motivated to go the nutritional and behavioral route. Find a treatment team that is willing to help you develop that plan and give you all of the evidence based strategies to address that desire for you.